This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. My name is Joe Sam Robinson, and it's my pleasure to have with us tonight Mr. Jim Marshall, who was, as Congressman, represented this part of the world for a number of years. Welcome, Jim.
Happy to be here, Sam.
And we've had some conversations earlier about different things, but I think we're going to focus a little bit on health care, which is something we care a lot about in this, at least on the show. I think you have some rather profound forebodings about that. I mean, are you concerned about the increase in healthcare expenses? And any comment about that?
Well, I don't see that any American couldn't be concerned about that. I mean, individual Americans see the cost of their insurance skyrocketing. If they don't have insurance, then they see the cost of any kind of access to medicine, to physicians, et cetera, skyrocketing. This has been going on for decades.
Yes.
All employers see it, and that's both public and private employers. I think all Americans are aware of the fact that health care costs are just flying through the roof.
Yes, yes.
What they don't understand is why that's happening.
Yes.
And I'm convinced that if people understood why that is happening, we'd fix it.
Well,
but they don't understand why that's happening, and so we haven't fixed it.
Yes. Well, just one little comment about this. I mean, there's been a lot of attention on cost, what things cost, which is natural and appropriate. But one of the things that's sometimes not spoken much about is value. And so if you look at the extension of life expectancy, the general idea, I mean, you're up in a senior decade here, are you not? And you're a pretty chipper guy. Actually, the system has produced, for people that have access to its technology, substantial advantages. I mean, and if we try and pay attention solely to cost, I mean, we could diminish the value the system grants us.
Yeah.
I mean, so is that an important caveat there?
What I am absolutely convinced of is that we would have the exact same advantages that you're referring to.
Yes, yes.
If the system were structured properly,
yes,
we'd have the exact same advantages that you're referring to.
Yes.
At half the cost.
Yes.
In addition, public health would be improved, and overall health would be improved. That's how bad the system is that we've got right now. There's no question that we through research, through great physicians, we do wonderful things.
Yes.
But the fact that we do wonderful things doesn't change the fact that we're paying twice what we should for it.
Yes.
And overall, the quality of care that we're getting is about average, and a lot of it is horribly sloppy.
Yes.
Particularly in large hospitals, and that's attributable to the way we go about paying for health care. That's the principal problem that we've got. Most folks don't understand it. I didn't understand it when I first started looking at the health care, reform proposals. And after a while, talking to folks like you.
Well, I hope I was able to cast some light into dark places. No.
But after a while, somebody who is familiar with how economies work, how businesses work, how people behave at a microeconomic and a macroeconomic level, look at this and go, this is an absolutely screwed up system.
Yes.
I wound up describing it as Soviet style.
Yes.
That we have a Soviet system. And the Huffington Post, you know the reference
there?
No,
I think that's
Arianna Huffington.
Yes.
All right, so I'm a Democrat describing our healthcare system as Soviet style.
Yes. Well, did they enjoy that comment?
Oh boy, I was attacked wildly.
Yes. Well, that's probably a slight compliment in that, I would say, if you're known by the quality of your enemies.
Well, and I've got them on both sides. I must be doing something right.
So you must. Yes. Yes. Well, I mean, the idea is the system has its extraordinary inefficiencies in it, and I think everyone would be in favor of of making things more efficient, diminishing expenses, making the system work even better. And then the question is, how does one in this complicated world take some steps in that direction?
Well, you can go ahead and tweak it, and you've got to. I mean, it's just a horrible management problem here. And so you can tweak it or attempt to tweak it in different ways by putting in different cost control measures, quality control measures, outcome determination measures. I mean, you read lots about this. Atul Gawande has had a series of articles that were pretty well received, trying to figure out what the cost conundrum in the New Yorker a few years ago.
I'm familiar with it.
Letting Go, his most recent New Yorker article. See, but I think all of that sort of misses the larger problem associated with healthcare, the heart of the problem. And it's very difficult to see because it seems so much a part of what healthcare must be, and it is health insurance. The problem that we have is too much of healthcare is paid for by third parties, whether it's the government, Medicare, Medicaid, or insurance companies. The new bill, the reform bill, will increase that percentage. 88% of the payments made for health care are paid for by third parties. Let's talk a little bit about what impact that has, and it's over a period of years. And it's really hard to do because a lot of people have a hard time seeing this. The best analogy, though, that I've come up with that people really understand, and it helps them understand it. Think about going out to dinner with some friends. And you all, in advance of ordering your meal and your drinks, you agree that you're going to split the tab. What happens to the overall cost of the meal when you agree to split the tab? Well, most folks recognize that. In fact, I know some people who won't agree to split the tab. Because I'm going to go out there and I know what I'm going to eat. And I don't want to pay for your steak and for that fancy bottle of wine that you wouldn't buy for yourself, but as long as I'm paying for it. So what happens when you split the tab is the cost of the meal goes up. Okay, so take that a little bit further. Thinking about splitting the tab, except you're doing it with total strangers. So you don't have any sort of social restraint associated with just sort of going wild and ordering the most expensive meal. Now, think about splitting the tab with total strangers, but they don't even have to go to the same restaurant you're going to. What happens to costs? Costs continue to go up. And I wrote a piece that I published in the National Review. For those of you who are watching, it's easy to find. If you just put Marshall Real Healthcare Reform, Marshall Real Healthcare Reform on any search engine, it'll pop up and you can read it. But in it, I describe, let's assume the entire country, everybody in the country is going to go out to dinner and split the tab every night. You don't have to go, by the way, but you're going to be splitting the tab with the rest of the country every night. What happens to the national economy and what happens to individual wealth if you've got a system like that? Well, you start thinking about it, that basically means I can go eat for free every night. The marginal cost associated with me eating whatever I want every night is zero. So what do? Do I go to McDonald's? No, I don't. I go to the fanciest restaurant around. I order the best steaks, and everybody else is doing the same thing.
Well, I mean, I won't joust with you on the subject. We get into some complicated issues with game theory and altruism and lots of issues. But actually, I take your point.
Actually, it's the prisoner's dilemma, and we're caught in it where healthcare is concerned.
But just one comment. Right? You know, the analogy of having a nice steak dinner and say a colonic examination is probably not quite the same. So many people might not necessarily embark on a lot of unpleasant tests.
What I'm trying to describe is how our system, as a result of the third party
I take your point.
Has exploded the number of procedures, the number of consults, the number of tests. Good doctors become specialists. They're not primary care physicians any longer. They don't touch people. They've got an automatic routine that they go, and it's because there's no real market forces involved at all where healthcare is concerned.
Aren't there some complicated things there? One of the issues I think you could say is, and maybe this is the era that I would say could be committed occasionally, and that's the idea of looking upon life as an economic situation. So everything is totally money, $5 bills, expenditures. But I think when we consider the healthcare issue, maybe I've made this point before, but a hospital is like a great cathedral, and the people repose lots of, I guess, attention to this cathedral.
Sam, you can have the exact same thing.
Yes.
For half the price.
Yes.
Think about that half. We've got 17% of the
Yes.
American economy right now
Right.
poured away into healthcare.
Yes.
You could have 9% of the American economy or 8% of the American economy into healthcare. If this was properly managed and properly done, we'd be healthier, you'd have the exact same
Yes,
opportunities,
yes.
and we'd have that 9% of savings
Right.
that solve our budget woes
Right,
altogether.
right.
Now, as it is right now, you continue to have this system, the one
Yes,
that we have
yes,
right now,
yes.
which is so different from
Yes,
anything else that
right,
Americans
right,
do.
yes.
No Americans have a system like this in any other sector of the economy. This is the only sector of
Not
the
even
economy
in
that's
agriculture.
driven.
Okay, just
Driven,
checking. Yes.
that's driven
Yes.
like this.
Yes.
So the upshot is that healthcare is going to become a larger and larger and larger
Yes.
portion of our economy, and we're going to become poorer and poorer
Yes,
and
yes.
actually sicker as a result.
Yes. Now, actually, I won't overkill the some of my comments to this. The takeaway message is we're in total agreement that we have to make the system more efficient and more effective. That's totally true. The idea that there are many structural problems about the way compensation occurs, I think that's a totally true thing. I think there are lots of things about the idea that if there's no check on using the resource, there's no reason not to use it, thus the resource is used more. But there are lots of complexities that go into this whole structure, and it's not so simple as it first one says. One reason is I was trying to make the point that healthcare is more than just numbers. There are all kinds of things that go into it. And it has oftentimes a quasi-spiritual quality to it. I mean, when people are very sick, they've got to do something. And one of the complexities is all kinds of ethical issues occur. When is it you're going to restrict care for a very small child? When is it you're going to punish somebody for eating too much? When is it you're going to say that particular drug can't be used or could be used? So all these decisions require extraordinary restraint. And I think the idea is we have this enormous ocean liner, and everyone wants to turn the ocean liner away from the iceberg. And the question is, what is the best way to do that? And I think one of the issues is, you've been in Washington, and there's an attempt underway to do that, to turn the ship away from the iceberg. And many people would wonder if the law that's been passed, the laws that are on the books, the laws that are being challenged in the courts, is that the way to turn the ship away? Or are we going to inadvertently make the situation worse? Do you have any comments about the Health Care Reform Act that was passed?
Yeah, no, I mean, earlier I mentioned that it's more of the same. It increases third-party pay. It limits much more than in the past individual consumer decision-making with regard to health care. And the effect of it is going to be to drive costs. I describe it as healthcare is our runaway economic freight train. It is hauling the country to bankruptcy. And what that bill did is just add a few more cars. That's basically what healthcare is at the moment. And I'm really pessimistic about Washington solving this problem. I think that American employers dragged us into it. They can drag us out of it, I hope. So here's the deal. We didn't have a healthcare system that was centered around insurance companies being involved in the very small, intimate, little tiny details. Just buy one pill, and the third party is going to pay for it. And you're going to go to a certain doctor, et cetera. We didn't have that prior to World War II. World War II, wage and price controls. In order to evade wage and price controls, what employers did was offer benefits. So retirement benefits, healthcare benefits. It was the first time insurance, where healthcare is concerned, became a big invasive deal. After World War II, unions kind of liked the negotiations that were associated with these benefits. So employers and unions were happy with that. The rest of the world was looking at the United States for leadership. And so at least in the developed, the free world, they sort of headed in the same direction. And then politicians followed with Medicare and Medicaid. And we've become this huge third-party pay sector. Healthcare has become this huge third-party pay sector of our economy, which doubles its cost.
Yes.
Absolutely guaranteed. Doubles its cost. Huge waste, fraud,
Yes,
and abuse.
yes,
Huge inefficiency. And because the system
Yes.
is not directly responsive to consumers who
Yes.
insist upon performance,
Right.
the effect is that the system is very sloppy, and an awful lot of
Yes,
people
right,
die
right,
as a
right,
result
yes,
of medical
yes,
errors.
Yes.
All kinds of problems with it,
Yes.
simply because of the structure. Now, how do you get away from that? I think that, and you and I have talked about this,
Yes,
you're a
right.
real leader where this is concerned. Several things. One, employers should head toward catastrophic policies
Yes.
with health savings accounts. The federal government should be supporting health savings
Yes,
accounts,
right.
individuals managing, and that health
Yes,
savings account is
right.
something that's owned by the employee.
Yes, yes.
And once the health savings account exceeds a certain level, the employee can do whatever the employee
Yes,
wishes
yes.
with that money. So the employee is paying attention to the money
Right, yes.
that's in the health savings account. The insurance company should be catastrophic only. It's not just
Yes,
high deductible.
right.
So the insurance company is not involved in who do you go to see as a
Yes, yes,
doctor,
right, yes.
what medications, et cetera. Just sort of more free market involved there. And the way the federal government can facilitate this is insisting upon price transparency. This is something that's been
Yes.
important to you. Price transparency and best prices for cash-paying patients.
Yes.
Best price. Whatever your lowest
Right,
price
right,
is,
right.
you
Yes,
give that
yes,
to a cash-paying
yes, yes.
patient.
Well, I mean, I think that's part of the story. It may be part of the solution. So I don't doubt that some of the economic glue that makes the system work it doesn't reflect what a true marketplace arrangement could make it. And the idea that you could have some benefit by not expending healthcare resources, economic benefit personally for you, I think is an issue. It's a good thing. But some of the complexities, let's remember this. If in some way the consumer responsibility, which is a big deal. So I think a consumer needs to be rewarded for a virtuous life. And I think in Switzerland, they do that. So if you have health insurance in Switzerland, you have it's a 5-year program. You come in, and if you turn into a fat boy in the interim, or you're not taking your blood pressure medicine, whatever, then your insurance premiums go up. I mean, so
we are right now as individuals paying huge bucks,
Yes.
and it's in the form of lower wages,
Yes.
lower profits, higher taxes,
Yes.
higher premiums.
Yes.
Now, at the time that we go see a physician,
Yes.
we've got a problem. It's like we're splitting the tab with the rest of the country.
Yes.
The physician is not really thinking about cost, and the patient's not thinking about cost. The physician and the patient are thinking about trying to do the best for that patient.
Yes.
But the effect is to do more tests,
Yes.
maybe a whole bunch of unnecessary procedures,
Yes.
and pass that cost on to all of us. And the effect is we're all poorer as a result.
Yes.
Many of us are sicker as a result. And if you look at the average middle class person who's going to have a family of
Yes,
four,
right.
all right, so 2 kids,
Yes.
and starts out, entry level,
Yes, right,
$35,000,
yes.
$40,000 job, and 40 years later, 35 years later, retires at $60,000, $70,000, $80,000.
Yes.
During that period of time, because of the way our healthcare system is
Yes.
set up,
Right.
about $1.2 million in
Right.
earnings
Yes.
of that individual through
Yes.
taxes,
Yes.
higher premiums, lower wages, etc.,
Yes.
are going into healthcare.
Yes.
Now, don't you think most people would prefer to have the $1.2 million for themselves and manage the situation on their own?
Well, it's a persuasive point. I'll make a few comments about it. And comment number one is I try to make just en passant remark about
By the
the
way,
benefits.
The setting here is about as uncomfortable as I can imagine. The seat's too deep, etc. But go
No,
ahead.
well, this is to concentrate your mind. It's kind of like the old puritanical church room, or if you're in let's say, a Calvinistic church, shall we say. It's a similar kind of thing. But the takeaway message is that the expenditures, I would say this, it's true enough to talk about the economic system. Where I come from is the idea of physician responsibility in this, and outcome analysis, and the idea that people that are actually ordering the test and expending these resources are physicians. And I think that's the part of the equation that's been left out.
For the benefit of the viewer, Sam's absolutely right.
Well, I'm happy to hear this admission.
Absolutely right.
Yes.
A good thing for people to read simple articles.
Yes.
written by a guy named Gawande, Gawande, Atul Gawande, published in the New Yorker, called The Cost Conundrum.
Yes.
The Cost Conundrum, New Yorker. What he does is he looks at McAllen, Texas, and El Paso, Texas.
Yes.
Similar populations.
Right.
At McAllen, Texas, costs are through the roof, procedures are through the roof.
Yes.
It's stunning how much stuff is being done. Population over in El Paso, Texas, not
Yes.
nearly as much medical costs, better health. Why?
Right. Well, I'm not going, it's probably not the right venue to discuss these New Yorker articles, but one of the things, we could get into some complicated issues here, but one of the things is subcategorization of patient population. So if you're comparing expenditures, you might have, there are subtle differences that might cause expenses to go up. But I take the point, and I think this is an important point, that there's substantial evidence, and the evidence I prefer is not found in the New Yorker, but rather in medical journals. There's a group at Dartmouth that's done great work on this, and they've looked at results in different parts of the country in regards to Medicare expenditures, and whether you're in a district, let's say, I'll pick Seattle, the amount of cholecystectomies done there versus Rochester, New York, the rates are different, there are different expenditures, but it doesn't seem like there's a substantial difference in health parameters as to what happens. To me, that's a more powerful kind of statement about it. But the point is correct, and I think what we get into is outcome analysis. And the big drum I beat is that if you look at medical journals and go through and say what people are suggesting in peer-reviewed journals, so let's do this, let's do it that way, let's do it this way. We drop the pain medication by 2%, but we don't mention cost.
Yes,
you may. Please speak.
So, given the current system that we have,
yes.
You've got to be doing stuff like you're trying to describe right now.
Yes.
You've got to have people looking at what's the best way to go about treating X, Y, Z, and then saying, physicians, this is what you should be doing. Don't do ABC, do GHQ, and lots of studies like that. Far better, frankly, to do those studies, to make that information available, and then let physicians be more responsive directly to consumers that they're taking care of. And in a relationship where the primary care physician is helping me not just manage my health, but also manage my money, instead of my money being squandered by this system. We're bankrupting the entire country. We're bankrupting states and municipalities, et cetera, over health care because of the way that it is structured.
Well,
I would rather see us change the structure. We'd be just as healthy. We'd be much wealthier, and we wouldn't have these debt problems that we've got right now. Social Security is a problem. It's easy to fix. Military expenses and the rest of the discretionary budget, they're minuscule compared to the size of Medicare, Medicaid.
Well,
gigantic, and the growth is explosive in those areas. You can't fix our budget problems with the rest of the budget. You've got to attack health care. If you don't attack health care, you're not going to solve it. And you can't solve health care by doing more of what we've been doing.
Well, we're in the same boat. We're each pulling our respective oar. So I think we're on the same team, Jim. It's just my comment about it, and I think the sharing of information is extremely useful. My comment about it is, we need to know what things cost. That's point number one. We need to understand what things cost. And we need to understand the benefits that happen when money is expended. And right now there's an enormous, if you mentioned the person that had the $1.2 million expenditure, really what happens, it's an end of life.
No, that's just sort of, that's the average.
Well, let me throw,
you're going to
I understand. But the real, where the money is expended often is an end of life experience. So for a normal person, maybe this money is accumulating, it's costing them this, and then in the last 6 months of life, in a terminal situation, that's when the resources are showered upon a person.
So how are you going to solve that problem in the current system?
Well, I think
are you going to have the death panels that people were worried about?
Well, we're on to some kind of complicated subject here, and that is, this is such a big part of our country that we need to have an ethical debate about what people can afford, what they want. It needs to be a public interchange about this. That's why this is a useful interchange. And one of the things that transpires, I keep going back to this outcome analysis. What is it? And we can't have a good outcome analysis unless we know what things cost. So when I write a paper, I might say, I'm going to do this, I'm going to do that, and then I try and get some idea of what things cost. by extracting that information from hospitals or drug companies, and I come up with, I can't get those numbers. So a real problem is that physicians have no idea what anything costs, and it doesn't make its way into our peer-reviewed journals. So it would be extraordinary to say, this is my idea about a new way to fix gallbladders. I'm going to, let's say, do this, and it turns out it saves $10,000 less. And those papers are rare as hen's teeth. We've gone through and we've used these search engines to looking at all the mentioned of all of American healthcare literature, and only 2%.
There's an easy explanation for why.
Yes.
There's no reason this system
yes.
would be looking for those kinds of savings.
Yes.
You think
because
about
it's a cost-plus deal.
Yeah, exactly. That's
yes,
basically
yes.
the system. You think about the annual negotiation between healthcare companies
yes.
and providers.
Yes.
What's going to be covered and what's it going to cost?
Yes.
Is it within the interest of the insurance company
yes.
to lessen the size of their market?
Yes.
No. Is it the interest of the providers to lessen
yes.
the size
yes.
of their market?
Yes.
No.
Right.
Both sides will want more things covered, and cost is something, it's other people's money that's
yes.
being
yes. Yes.
discussed between
yes.
these parties when you're talking about what's going to be covered and what it's going to cost. The system is so screwed up, but it's also very hard to see
yes.
that it's so
yes.
screwed
yes.
up. And the easiest way to do it is think about splitting the tab for dinner. And,
yes.
and also you can think about real simple settings. For example, assume it's the 1940s.
Yes.
Dr. Robinson, I go to see him.
Yes.
It's my money.
Yes.
I present a certain way.
Yes.
And you would be thinking, okay, this could be one of three things.
Yes.
Jim, let me suggest that you take test number 13. It
yes.
could be that test number 14 or number
right.
15
yes.
would be appropriate. But let's take 13, couple of weeks, we'll see
right.
the result.
Right. Yes.
All right. Introduce insurance to the
yes.
situation.
Right.
I go see you with
yes.
insurance.
Right. Yes.
Now it's not a $20
yes.
coming out of my
right.
pocket.
Right.
You know
yes.
it's $2 for the copay for
yes.
each of these
yes.
tests.
Right.
What do you suggest?
Yes.
Take all three tests.
Yes. Well, let me say, let's introduce one other figure in this little psychodrama, and that's a lawyer. So let's have a lawyer sitting there. I mean, so I'm joking slightly, but not totally.
No.
So the paradigm.
Let me, I'll take that.
Well, okay. No, wait. I throw you. All right.
So no, wait.
You don't have a problem. Go ahead. Speak.
So
I don't want to be mean to you tonight.
I'm with you. So think about now insurance is involved.
Yes.
And Sam,
yes.
With his patients like me,
yes.
is ordering 3 tests.
Yes.
Dr. Smith
yes.
sees what Dr. Robinson's doing
yes.
and goes, geez, you know,
right.
Sam is setting a new standard
yes.
of care,
yes.
and I might get sued if I don't follow that same standard of care. So Dr. Smith starts doing the 3
yes.
tests, and then Dr. Jones starts doing the 3
yes.
tests.
Yes.
And then somebody thinks, well, you know, really, in this setting here,
yes.
maybe somebody presenting like Jim presented
right.
should go see a specialist.
Yes, yes.
And all of a sudden, the standard of care, again, driven by insurance,
right.
the fact that it's just a little copay.
Right. Let me make just one. I think you've come upon an extremely important point, and that is, number one, standard of care really comes out of tort law. So it's not a medical term. That's the derivation of it. Something coming from the medical side of the fence, we have clinical guidelines. And there's a difference between the two because of the absolute nature of standard of care and the tentative ideas about clinical guidelines. Just to keep talking about it, one of the things I fear and I'm concerned about is in the idea of trying to diminish healthcare costs. What occurs is there's some kind of, I'll use the phrase, cookbook medicine or algorithms that are put in by external agencies without the appropriate clinical information. So there are no good studies. Someone says, well, it looks like you have cancer. I'll see what this costs. In my clinical guidelines, and I'm going to say it's like a standard of care, I'm going to have that, the force of law, the force of everything behind this. You have to go home and wait 6 months and then come back and see me and we'll talk about it. And the reason that's been put in there and propagated is just to save money, and that's a very substantial danger.
Yep,
you're almost finished. You've got one rebuttal or comment.
Well, no, the observation is this. Struggles like the one that
yes,
you described
yes.
occur because of the system that we have.
Yes.
The health care reform bill is not going to solve
yes.
the cost problems with this system
yes.
unless you do these kinds of things that people won't tolerate.
Yes.
So the upshot here is we're going to have to revisit this. And
Yes.
if more people understand how screwed up the system is
Yes.
simply because it's too much third-party
Yes,
pay,
yes.
we can head the system in a better direction. If it was more consumer-driven,
Yes.
if there was more responsiveness
Yes.
by physicians
Yes.
to the consumer,
Yes.
worries about the consumer,
Yes.
we'd all be healthier, we'd be wealthier.
Great. Jim, thank you so much for
Yes,
being
sir.
here. You made some very germane comments. Thank you.
Thank you.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.